Hello, doctors. We'll go to study ectopic pregnancy today. Please, before watching my video, subscribe to the channel. Okay, ectopic pregnancy. Ectopic pregnancy embryo implant outside of the endometrial cavity. So the fetus is growing outside of the endometrial cavity. So it has different sites. It can be cervical, interstitial, perineal, isthmal, ampulla, infundibula, and ovarian. So in any of those places, 7 places, it can grow and cause problem. So what's the etiology? 50% due to damage of the fallopian tube cilia following by PID. So the pelvic infectious diseases are one of the major causes of the ectopic pregnancy. Intrinsic abnormality of the fertilized ovum, conception late in a cycle, transmigration of the fertilized ovum to the contralateral tube. Okay, so here's a table which is important to know about it. So first of all, positive urine beta HCG we're checking for, abdominal pain, vaginal bleeding. 3 main symptoms. Okay, it may be hemodynamically stable or hemodynamically unstable. So if the patient hemodynamically unstable, we are going to make a surgery. So if stable, we are doing transvaginal ultrasound and serum beta HCG. So we are going for the next step of the treatment and we will find out what to do in a different kind of situations. So we're going to below the risk factors are previous ectopic pregnancy, gynecological. It can be current IUD use, history of the PID, infertility. So infertility treatment is IVF pregnancies following ovulation, induction by 7% ectopic rate. Previous procedure, so the surgery can be also one of the risks. Previous surgeries. Any surgery on the fallopian tube can be the cause. Abdominal surgery for ruptured appendix, smoking, and structural, like uterine leiomyoma and adhesions. So those are making risk factors. So the next is investigation. First of all, serum beta HCG level should be checked, and ultrasound. So mostly transvaginal ultrasound is most diagnostic for this. It's useful actually. Suspected ectopic pregnancy in the case of empty uterine by transvaginal ultrasound with beta HCG more than 2 to 3,000 MIU per milliliter. Okay, we have another method which is laparoscopy, sometimes used for definitive diagnosis. So what are the treatments in this case? So we have conservative, maintain hemodynamically stable. So surgical laparoscopy. So linear an option if the tube are salvageable with weekly beta HCG. So we are going to do beta HCG follow-up. And so by the way, salpingostomy, it's a better choice actually. Okay, persistent trophoblastic, if salpingostomy is done, there can be such kind of risk to trophoblast to be growed inside of the tissue, and it makes problem like it will be a second surgery and removal of all of that tissue because of growing of the trophoblast. And salpingostomy, if the tube damage or ectopic, is ipsilateral recurrence. Okay, so we have methotrexate treatment, which is folic acid reductase inhibitor, affecting the rapidly dividing of the cell. So use 50 milligram per meter square body surface area, given as a one-time intramuscular dose. This is 1 out of 5 chemotherapy dose, so the minimal like side effects are available. And we have to make a follow-up beta HCG level on the days, like for 4 or 7 days after the injection we are doing it, and we are checking beta HCG. So rising the level of the suggested persistent trophoblastic tissue requires further treatment. So if the trophoblasts will grow inside, so we need another kind of treatment. 82 to 95% success rate, but up to 25% will require a second dose. Administer a second dose if the beta HCG does not decrease by at least 15%. Tubal patency following methotrexate treatment approaches 80%. Stop perinatal vitamins as of folic acid because it is decreasing the effect of the methotrexate. Expectant management is an option for the patient who are clinically stable, reliable for the follow-up, and have beta HCG level that are low and declining. So ectopic pregnancy, it's one of the like pregnancies which is really dangerous. It's starting with severe pain. It can be asymptomatic and rapidly right after the rupture of the fallopian tube, especially in ampulla, it's mostly happening, and only after rupture and bleeding will appears. So that's why it can be dangerous and irritating the peritoneal cavity, and that can be one of the causes of peritonitis also. That's why follow up and like right diagnosis in a good time is really good.